lecture slides have pretty much all the information on it. So part of infectious disease, I'm going to talk a little bit about a bunch of things: bites, animal bites and human bites, MRSA, and necrotizing fasciitis. Some fun stuff. Okay, infectious complications of bites. Anytime you get a breach in that outer protective barrier of the skin, it's going to be potential for infection, and that's what bites do. It allows that bacteria to get past the outer skin and down into deeper tissues. It's pretty common, especially in your ERs, and obviously primary care or urgent care, probably more so. The majority of these are going to come from our domesticated pets, dogs and cats. You know, what the particular or the flora that can cause infection oftentimes is from what's in the mouth, but it can also be from soil, from just our skin, or potentially feces from the animal or another animal. What's important to know is that cats and human bites have a lot greater risk of becoming infected than even human bites. You always need to take into account what type of animal, obviously, because some are going to be more prone to infection than others, where on the body the bite took place, and that sort of thing. Type of injury, is it more of a scratch? Is it an actual bite wound? Is it a puncture wound? That sort of thing. Certain parts of the body are at a lot greater risk of infection. Your hands and any extremity, but especially your hands, are a lot more prone to secondary infection versus on the face and neck area. You've got a lot better blood supply to the face and neck area, and they just tend to heal faster and become less infected. So again, most of the bites are going to come from dogs. About 15 to 20% of these will become infected. I don't expect you to know those percentages. That's just more for your information. And it's usually an animal that we know. This actually happened to me a number of years ago. I have just a mutt right now, but before that I had two chocolate Labrador puppies that were two sisters out of the same litter, and one was extra ornery and the other was extra sweet. Well, the extra sweet one, I was down on the floor with her, and she accidentally got a hold of my nose, and we kind of went in opposite directions and tore my nose here, and so I had to go into the ER, and I ended up having to get 15 stitches up there in my nose. So what's funny is it says here that most bites are to the extremities. For those that are 4 or younger, apparently I was acting like a 4-year-old or younger, to the head and neck area. So I was on the floor. It was all my fault. She was not meaning it harmful at all. We were just kind of playing, and it just happened. But they did. They asked me a lot of questions about, did you know this dog? You know, did you provoke this dog? I'm like, no, I was down on the floor with it, just playing. I was being stupid. But anyway, so you do kind of want to find out if it's a provoked. You know, did you do something? Did you wake it up out of sleep? Were you playing with it? Or did you mess with it when it was trying to eat? Those are going to be provoked attacks, especially in our domesticated animals. Now, our wild animals, you can throw that out the window, because it's hard to know when you provoke a wild animal or not. So, again, 30 to 50% of your cat bites are going to become infected, and that's a big reason for that is because it's more of a puncture wound rather than a tear. So you just get that inoculation of the bacteria deeper down into the tissue. Usually the infections are polymicrobial, meaning a number of bacteria. You're going to need to know this. Pasteurella species is the most common, especially in cats. 75% of bites from a cat that become infected are due to Pasteurella, and 50% of dog bites are due to Pasteurella. And I have seen that on a board exam or a PANRA exam. So make sure you know this not only for my test, but for future tests. Other common aerobic and anaerobic bacteria are there. I don't necessarily expect you to know those, but I do want you to know that Pasteurella. What's kind of interesting about the Pasteurella, a secondary Pasteurella infection, is it presents itself pretty quickly. Within 8 to 24 hours, it's going to start acting infected. It's going to start getting red and inflamed and result in some purulent drainage. Other sources of bacteria or other bacteria can potentially take, several days to start looking infected. You always need to think about a deeper infection into a joint or into the bone, especially if that bite involves those areas. So you need to take a close look at these bites. Look inside that wound and see what it's involving. That last thing that was just kind of an FYI. So human bites can be self-inflicted. You got a crazy person in the emergency room and they're biting themselves. They could bite you potentially. A bar fight, accidentally, especially if you see a bite, especially over this MCP joint, I would assume that it is due to a brawl versus anything else. It could just be an accidental, kind of got hit the tooth and opened that skin up. So again, any bites, whether it's human or animal, on the hands are a lot more prone to infection, especially over that MCP joint. Again, you've got a bunch of different bacteria that can cause secondary infection, and you have to also think about some other infections, such as your hepatitis, your herpes simplex, tetanus. With any bite, human, animal, spider, which we'll talk about, you always need to ask about their tetanus and update that if they are deficient. Okay, and know that if you have deeper involvement of that bite, if it's involving the tendon, the joint capsule, anything like that, get a hand surgeon or an orthopedic surgeon to come take a look. Anytime you have a person that's immunocompromised, or a person, if they had sustained a bite to an extremity with a lot of swelling or compromised lymphatic drainage, that's always going to set you up for slower healing as well as potential secondary infection. And in fact, I probably told you back when I would get biopsies from the lower leg, I almost always put somebody on an antibiotic if it was someone that had, they just had edematous legs and that sort of thing. So you can imagine when you've got a bunch of bacteria in there along with it. So you have to think about, again, we talked about what type of wound. Is it a puncture wound? Is it a laceration wound? Is it just a scratch? The depth of that penetration of the bite, and then any other deeper involvement, even bones. I would suggest that you get a picture and keep that in their electronic medical record. Always get a gram stain and culture and sensitivity. If you can get the deeper you can go in that wound, the better. If you're just kind of swabbing up on top, you're going to mainly just get the person's skin flora. So try to get deeper into that wound. Very important to vigorously clean and irrigate. I, honest to God, thought I was going to drown when they were irrigating my nose because they were just, pushing syringe after syringe after syringe, and I was just like, let me breathe. So, and then when they put the lidocaine in my nose, oh my God, I have a new appreciation or empathy for people that get any kind of lidocaine in their face and nose area, because it hurt pretty bad. I said a few choice 4-letter words. I happen to be at Mercy Hospital, and I happen to be Catholic, so I thought they're going to send the priest down and get the holy water on me. So if you think think that there might be a foreign body, a broken tooth, or anything, don't hesitate to get x-rays. Okay, a lot of controversy as to whether you suture up these bites or not. There are certain conditions when you definitely don't want to. I would really strongly discourage it if it's infected already. You know, your bites are they are usually gonna be delayed to go into the emergency room or the urgent care clinic, and they're probably presenting as an infection, secondary infection. Cat bites, the deeper ones, you don't want to close up. I would say if it's a pretty gaping something, but it's secondarily infected, you might put in a few stitches just to bring it closer together, but I wouldn't completely close it up. Facial wounds, like I sustained, they're going to usually suture those up for cosmetic purposes, but you really have to do some good thorough irrigation, not irritation, sorry. I had a typo here. All right. Prophylaxis antibiotic, me being who I am, I'm going to probably put any bite on prophylaxis antibiotics, but you for sure want to, in certain populations, cat bites, any location, hand bites from animal, human, no dog, whatever, and obviously if you have people that have other comorbidities and they are at greater risk of getting infection. I don't know if Dr. Latassi is going to be giving lectures about, then kind of keep my information kind of in the back of your head for future reference, but I won't test you over it. So I don't have any of my test questions over this. Sound good? All right, let's talk a little bit about rabies, the potential complication. This is a rapidly progressive infectious disease that affects the central nervous system. It is essentially deadly. I think in the reading that I did, there was less than a handful of people that have actually survived a rabies infection, and they don't really know how that happened. Worldwide, it causes a lot of deaths, 55,000 deaths annually, mainly in Asia and Africa. Here in the United States, it's more from wild animals, not so much our domesticated animals, but our raccoons, skunks, bats, and foxes. Here in Oklahoma, it is mostly skunks and bats have the highest rate of rabies. So it's transmitted via an animal vector. They have the infection in their salivary gland, and via the saliva with the bite, they can transfer that to us. All right, so the virus itself, sorry, I just want to make sure I didn't miss something. Rhabdoviridae is the name of the virus family. Those two types of virus are what cause human disease. So occasionally, usually it's via a bite and the saliva. Every now and then there have been case reports of infection via other contamination of other mucous membranes, such as the eyes, the nose, and mouth. They had some where it was aerosol transmission. That I read mainly was like caves with a bunch of bats and their feces, and that aerosolized, and that rarely has caused infection, as well as corneal or organ transplants. So, what's important to know, I would like you to know, and this is actually a good thing because it's such a deadly infection. It actually has a very long incubation period, and that virus during that incubation period stays very local before it starts to spread. So, you know, half a month to 3 months time of incubation. So that is a good length of time to get on treatment if you are at all suspicious. So It basically binds to a certain the nicotinic acetylcholine receptor, and it's spread along the peripheral nervous system, and then to the central nervous system, and then spread throughout systemically to other tissues and organs. It basically results in an encephalitis of the central nervous system and the basal ganglia and the spinal cord. I do want you to be familiar with this Negra bodies. Negra bodies are an inclusion body that you find in either nervous tissue cells or just other organ tissue cells where that virus replicates. When they see that under the microscope on histology, that is pathognomonic for rabies infection. Now, if they don't see it, it is not an automatic exclusion that that infection doesn't exist. But if they see it, it's a slam dunk. And you're going to mainly see that on the nervous tissue, if they euthanize a wild animal, and then they can get a tissue from the brain, and they'll look at it under there, for there. Basically, two forms of rabies. You have your encephalitic or your furious rabies, and your paralytic or your dumb or apathetic rabies. And just by hearing the name, you can almost get the picture of what a person would look like. With the encephalitic, you have just overall hyperexcitability. So these people tend to be very confused, have bizarre behaviors, hallucinations. They may drool, have hypersalivation, their body temperature goes up, their heart rate goes up, they get hypertension, cardiac arrhythmias. They're just in this state of hyper everything. Paralytic is kind of the opposite extreme, where you tend to get paralysis initially to the limb or wherever the bite took place, and then that can spread widespread, including facial paralysis, and that progresses to coma and organ failure. Coma, I mean, this happens quickly. That coma can occur within 10 days of the symptoms starting up. And even before these two, those are more the neurological symptoms. Before that, you kind of have a prodrome where it's just more flu-like or viral-like. The death is actually just from a number of things, cardiac arrhythmias, you name it. There are a couple of particular things, this hydrophobia and aerophobia, that are kind of classic or known to be symptoms that you can see with rabies. Hydrophobia and aerophobia are both where a person gets these severe spasms of their pharynx, larynx, and the diaphragm, one either with drinking fluids or when you blow air into their face. And then they can kind of foam at the mouth is what that is. And this just kind of talks about each clinical stage and kind of the time frame and that sort of thing, but we just talked about that. So within 2 days, 2 weeks, you are dead. And what's difficult too is it's incredibly difficult to diagnose rabies. You just have to have a very high clinical suspicion. A lot of your labs, your MRIs, your CT scans, your cerebrospinal fluid, lumbar puncture, they're not going to help you. They can get some testing, some antigen and antibody testing on certain parts of the body, the saliva, the cornea. I think what I read the most was actually skin biopsy, and the best place to get that is actually back here on the nape of the neck, because you get a larger quantity of that virus antigen at the base of cutaneous nerves, where there's at the base of hair follicles. So that's where they recommend to get a skin biopsy. obviously the brain biopsy, you're not gonna do this on a human being, but if post-mortem, they may get a brain biopsy, but that's especially if it's a wild animal and you can catch that animal, they will euthanize it and then get a biopsy from their brain. There are some other tests with the saliva and cerebral spinal fluid that will look for the viral RNA. But from what I read, it was more the tissue antibody that they used more so. So again, a negative test, there's a lot of false negatives. So a negative test doesn't necessarily rule this infection out. Again, if you have a high index of suspicion, you're going to repeat these, in a week or two. Didn't know it was my schizophrenia acting up. Okay, with rabies, well, again, with any bite, this thorough wound cleansing is vital. They actually found, studies found that just that alone can really decrease the potential risk for infection with rabies, even though that virus is there. Again, you always need to ask about their tetanus and give them a booster if they're deficient on that. Again, what's so tough is there's no good treatment for rabies. They have done a bunch of different things and nothing has really been found to be helpful. So what is incredibly important is to get on post-exposure prophylaxis, which we're going to talk about here in a little bit. What I did want to mention, and I want you to know, is that steroids are actually contraindicated. They tend to shorten that incubation time, and they found increased mortality if you give steroids. So uniformly fatal, unless if you treat with post-exposure therapy. All right. So you want to find out what kind of animal bit your patient, and you need to find out, whatever state you're in, if that animal is at high risk of carrying that rabies virus. You need to find out what type of exposure. Was it a true bite or was it just a scratch? There's a big difference in potential rabies, passing on the rabies virus with a bite versus a non-bite. And then if you can get that animal captured, that's ideal, so that then they can euthanize that animal. Now, they're not going to usually euthanize, like my sweet doggie. She said we're going to euthanize her because we knew she'd had her test or her rabies shots and whatnot. But a wild animal, they will try to catch and euthanize that. Now, for a domesticated animal, they will, and it's not an animal that's known to you, they will take it and seclude, or put it in a, well, you probably know this better than anyone.
Kennel too.
Do what? Oh, you
kennel.
did too, that's right. They'll watch it over, 10 days?
Yeah,
To
10
see
days.
if it changes behavior. If it does, then they're gonna treat you as though you've got rabies. If they don't, what would they do then? Would they go ahead and treat, or you're fine? I think if they can watch the animal for 10 days and they don't change behavior,
Usually they can, yeah. We had one though that was a bite that they just, like the person who was bit forced to underneath the dog anyway. So sometimes that happens. But for rabies protocol, I feel like usually it's
You
just
said
10 days.
You usually get a prophylaxis because it takes 10 days for them
to
to
show that.
They take up to 10 days to show.
Yeah, so if it were me on that receiving end, I would probably want the
Yeah.
prophylactic treatment, but, and there's a little, I'll show you here, here in a little bit, I have kind of a chart for what to do. Again, with a wild animal, you can't determine whether a bite was provoked or not provoked. All right, so when we treat prophylactically post-exposure, we give both active and passive immunization. The passive immunization is when we give immunoglobulin. And the names for that is Immugram, and Hyperrab. You want to make sure you give your dosage of this within 7 days. If it's beyond 7 days, don't do it, because they say that that is actually keeps your body from forming its own antibodies, can decrease your body from doing that. So if it's within 7 days, give that immunoglobulin injection, and it's a 20 units per kilogram of body weight. Typically what they do is they give that injection right around, with multiple sticks, right around the area of the bite. And if it's like a smaller surface area, like a finger, they'll get as much as they can and then do a separate location. Now the vaccines, there's 2 different vaccines that they use in the United States. You give 4 separate 1 millimeter or 1 mil dosing intramuscular, and that has to be intramuscular. They have reports of, you know, it being given in the gluteal and it didn't get into the muscle, and then they developed rabies. So you need to make sure you do that. So you give your first dose on day 0, day 3, day 7, and day 14. For immunocompromised, they give 5 days, an extra dosage. All right, so if a person has had rabies vaccination, they're just in a high-risk job and they have had rabies vaccine given before, then you don't need to give the immunoglobulin. You just give 2 dosages of the vaccine at day 0 and day 3. You never want to administer both of those, the vaccine and the immunoglobulin, in the same syringe or at the same body location. And pregnancy, this is important to know, pregnancy is not a contraindication. So if you have a gal that comes in who's pregnant, treat her. And then that's kind of your algorithm for your post-exposure prophylaxis. And then, like I said, they do have pre-exposure prophylaxis for people that are in high-risk jobs or whatever. Okay, let's move on to spider bites. Ton of spiders around. There's only a small percentage of them actually have fangs that are big enough. I know, I just got the heebie-jeebies. I hate these pictures. That are actually long enough to penetrate the skin. Most of the time, any spider bites are pretty minimal. You're gonna get, you know, localized, just a reaction to that venom. Your skin's gonna react by becoming red and swollen and painful and or itchy, and then it'll just eventually go away. There are a couple of spiders that can potentially be a little bit more dangerous, and the sequelae that they can cause is called lacrodectism. I'm not gonna, you don't have to know those terms. The black widow spider and your brown recluse, but just be familiar with those other terms. And I don't even know how to say that other one, so I'm not going to. Okay, so black widow spider. This is predominantly in the southeastern United States. I know we have them here. Both of these spiders kind of like these dark, undisturbed areas. They generally, both of them don't tend to be real aggressive spiders, but if you disturb them, they will then bite you. So a black widow, has anyone seen a black widow in person? Yeah, thank God I haven't. They tend to be shiny black. On the underside of their belly, they have this red hourglass marking that makes them stand out. Females, apparently, are more potent. Oftentimes, that you will feel a person will feel the bite of a black widow, where they generally don't feel the bite of a brown recluse. All right, so basically the venom of the black widow causes a loss and a complete depletion of acetylcholine. and norepinephrine. This results in severe muscle spasms, anywhere from the limb or whatever where you've got the bite to widespread muscle spasms of the abdomen and trunk and large muscle groups of the legs. And this can take several weeks for it to resolve. You can sometimes have other things that associate the muscle spasms, such as increased salivation, diaphoresis, increased urination, defecation, some stomach upset, and vomiting. Rarely, you can have even renal failure, rhabdomyolysis, respiratory rest, and that sort of thing. And again, always the either end of the bell curve, you're very, very young and you're elderly or debilitated or at greater risk. We don't have real good treatment for this. There is an anti-venom available, but not in the United States. No, I take that back, that's for the brown recluse. There is one available, but they've had a lot of reported severe allergic reactions to it, so they're a little bit leery to, just give this willy-nilly. Sometimes you need to admit somebody for very severe cramping, and you may need some of these medications to just calm that muscle spasm down. But mainly it's just rest and ice and elevation. Ugh, that's what that looks like. Okay, is anybody else skin crawling? I hate spiders. It's like in my household, my husband is a big chicken with anything flying, so I have to always go after the bees and the wasps, and he has to go after the yucky spiders. Okay, so brown recluse, again, we have brown recluse here down south central United States. What kind of makes them stand out, and there's a lot of spiders that can look like a brown recluse. What can make it stand out is it has this violin shape on its cephalothorax. That's the small part between the head and the abdomen, and that's where the legs come out. The neck of that violin actually points towards the abdomen, and I'll show you a picture of this. Another thing that is more outstanding for this versus other spiders that can look like a brown recluse is they actually, most spiders have 8 eyes. I didn't know that until I was reading them. 8 eyes. This spider has 6 eyes in sets of 2. Where most, I'm getting these looks like you're just creeping me out. Most people have 4 sets of 2 eyes. So if you want to look real close, you can look at their eyeballs. Okay. I think we said all that. You don't need to know what the active enzymatic components are. I just put that in there for if you're ever on Jeopardy or something. So again, even with this, and most of your brown recluse spider bites are minor, and they will just pass without anything. Occasionally, it can cause very severe necrosis of the skin and subcutaneous tissue, and can sometimes even cause some other systemic problems, hemolysis. So this one, most people don't feel that. They just, the next day start noticing a change on their skin. It's going to be usually when, and these like to hide in clothing and shoes and cupboards, and you put a winter sweater on that you haven't had, and you start having changes. All right, so it tends to be kind of pruritic, itchy, and painful. You get this central area of firmness or induration, surrounded by these zones of paleness and increased redness, or ischemia and erythema. That sometimes, in severe cases, that will continue to spread out. You tend to get kind of a hemorrhagic look, a purpley discoloration with blisters, and then you will just form this thick Escar, that thick scabby thing. That will slough in several weeks, and then you have this resultant, just area of necrosis and just a ulceration. I have seen these bites. I've never seen a really bad one, thank goodness, but I knew of somebody at an old clinic where I used to work. Okay, so about 50% of the people will also develop fever and other systemic symptoms within 3 days. The good thing that I would always tell people is that if if they come to me 5 days out and it's still looking pretty benign, I will tell them, the good thing is this presents pretty quickly or presents earlier and more quickly, so I think you're in pretty good shape right now, so. So you can get renal failure, rhabdomyolysis, hemolysis. With that, I would always check when I would see them. I would check a CBC and CMP and repeat that in a week and just make sure. Again, don't have really good treatment for this. Rest, ice, compression, elevation. They do not want you to put heat on it because they feel that can spread that toxin around more quickly or easily. We would, in the clinic, if we were suspicious of that, we would use local injections, several injections of steroid, Kenalog, 10 milligrams per cc, and just do several right around there in the real indurated area just to calm all that down. I mean, we had, again, I never really saw a bad one, but that is something. I know they've done studies on even your topical vasodilators, like nitropaste, that sometimes people will use on their chest when they're having angina to help vasodilate. They've tried studies with that. I just don't think it does much good. So, some people said cut the whole thing out early on, others it's just very controversial as to the treatment for these. But again, I would recommend that you check a CBC, CMP, if you're suspicious of that, and then follow back in a week. And there is that violin shape on that area where those legs are coming out, and the neck is pointing towards the abdomen. On the left side, you see those 2 or 3 sets of 2 eyes versus 4 sets of 2 eyes that most spiders have. And this is an example of a brown recluse bite. You can kind of see the progression, pretty quick progression from day 3 to day 10. Within a week, he went from, redness and a little bit of that ecchymotic look, and I'm sure there's induration there to necrosis and yuckness. That is a technical term, isn't it? Yuckness. All right, MRSA, methicillin resistant. So MRSA is a strain of Staph aureus. Initially was only seen in the hospital setting, or hospital acquired, or associated, not acquired, but hospital associated MRSA. Back in the 90s, I think, is when it started creeping out into the community. So they have a community acquired MRSA. And they tend to present a little differently. Obviously, the hospital acquired is a lot more invasive and severe because it can get in more systemic into the lungs, cause pneumonia, bloodstream infections, deeper wound infections, osteomyelitis, where your community acquired tends to be just on the skin. in the form of abscesses and folliculitis, so I think I covered pretty much all that. Pyogenic skin and soft tissue infection in the form of boils, deep abscesses, and cellulitis. Occasionally can cause some deeper things. I was kind of surprised by this. Oh, less than 2% of the population is colonized. I would have expected it to be a lot higher than that. I wouldn't be surprised if I had it, just because I would see it so much, you know. But who knows? Your hospital associated, they're going to treat a lot more aggressively with IV medications and isolate them and make sure that a person gowns up and covers up anytime they go in and out of the room. Not so much with the community acquired, but you can, others in your household can become exposed to it and colonize with it, and they can start having problems with abscesses and things like that as well. Your primary treatment, if you have a person with a community acquired, is IND, if it's a larger abscess. Obviously, a folliculitis, you can't IND every single one of those, but if you have a single abscess, the best thing you can do is IND that. You're gonna give antibiotics, and they say even if you IND it, you sometimes, oftentimes won't even need an oral antibiotic. You will want to treat with oral antibiotics if a person is getting at multiple sites or repeated problems with this, or for certain if you've got a person that's immunosuppressed or has other comorbidities. Again, your options are your clindamycin, sulfa-based, Bactrim. I almost always use your doxycycline or minocycline. I'm just a little bit nervous to use Bactrim, but I will if I have to. Another thing too, and this talks about decolonization. I don't think you can ever completely decolonize that bacteria. If it becomes part of your flora, it's part of your flora. But what you can do is help to reduce how much of that bacteria you carry on your skin, and these are some ways that you can do that. Again, the areas where you carry more of that, that bacteria is up in the nose as well as body creases. So it talks about swabbing mupirocin or Bactroban twice a day for 5 to 10 days up in the nose, and then using an antiseptic solution. I would just recommend that a person uses an antibacterial wash, especially in the body creases. If that doesn't cut it, then I would have them use their mupirocin, not only in the nose, but in those body creases where there is more of a problem. Say they would always get their abscesses on the buttocks and the legs, then I might not necessarily make them treat the axilla, but I'd have them treat their leg creases and gluteal crease. Another thing you can think about, especially with young kiddos, especially your atopics that have eczema and they're getting these secondary MRSA infections, is to get them exposed to a dilute Clorox bleach bath. And I usually say if they're really flared up and having problems, I would say do that daily for a week or so until the flare calms down, and then maybe do that a couple times a week, 2-3 times a week for maintenance. So again, it's not a true complete decolonization, you're just lowering the load. And this is what it's going to present like. And I remember back when this very first started presenting itself in the community, I told a number of people that was a spider bite until I found out about this strain of methicillin that presented itself like this. So with that, what are you going to do? IND. That obviously has pus that needs to come out of there. Sometimes it can be a little early, if there's just hard induration, you could try to open it up a little bit. There may not be much of anything that comes out, but you could always say, I think it's a little early, but let's keep some warm compresses on it. Let's bring you back in a few days, and see if we can open it up then. All right, our last little subject is necrotizing fasciitis. This is a really fast progressive infection not in the top layer like a cellulitis is, but deep down into the tissues along that fascia. And you get necrosis of the subcutaneous tissues. There's a couple of different types, type 1 and type 2. Type 1 tends to be polymicrobial, and the much more common of the two, 90% of necrotizing fasciitis is of this type. Usually a person is going to get this from some other trauma or perforated bowel or a surgical procedure or something like that, where your type 2 is monocrobial, it tends to be the group A strep. But MRSA is becoming more prominent as a single microbe. Your two greatest risk factors for the development of this bad infection is diabetes and severe peripheral disease, vascular disease. One thing I do want you to know up here, I forgot to mention, is Fournier's gangrene is a particular type of necrotizing fasciitis that is in the groin and genital region. It's a pretty bad thing. All right, so again, you just have rapid progression of redness turning into kind of that purpley ecchymosis look with blisters, and then it just becomes necrotic tissue. And again, a lot of this is occurring deep in the skin, so they are hurting really bad, and they present with a lot more pain than some, or especially early on, they present with a lot more pain than what they look like they should have. High fevers, unrelenting pain. So, what's kind of interesting too is as this progresses, they tend to have less pain, actually anesthesia, because they just lose those cutaneous nerves. So they just lose that sensation of pain there. You're gonna refer this on to a surgeon, and they're gonna open that area up and obtain a deep culture, maybe get a sampling of the tissue so they could look at that under the microscope. Your MRI, CAT scan, ultrasound aren't really gonna help that much. Just mainly opening it up, getting the sampling of the tissue. The most important thing about this is referring on for surgical debridement. I mean, this can save a person's life. If you can get that first debridement done within 24 hours, it can save a person's life. And they want to just go be pretty aggressive, get all of that just necrotic tissue and junk out of there, and they may need to do that several times to continue to get that necrotic tissue out. It may even require amputation of a limb to completely get a grip on it, get ahead of it. You're always going to start antibiotics. You're going to get your culture, but you're not going to wait for those results. You're going to get them on antibiotic. Hyperbaric oxygen has been suggested as an adjunctive therapy. Again, big mortality of up to 50%. Again, depending upon their underlying health, it just is a very rapid progression of this infection. And you can get multi-organ failure. And that is there on that left leg. You can just see those areas of redness, erythema, and that kind of purpley ecchymotic area, and then the black necrotic eschar. And that was I was nice to you with the picture. There were some nasty pictures that were available. Okay, I think I'm done. Do you guys have any questions? We're done for the day? Woo-hoo.